This week on the BackTable podcast.
We need lots and lots of obstetricians in Australia and New Zealand. We don't have enough. So there is always a big focus on obstetrics. As president of AGES, I've really been trying to build the relationship with RANZCOG. It hasn't been great in the past, but I think we actually got a really good relationship with RANZCOG at the moment. We have regular meetings. We talk about things we want to achieve together. We actually have a combined committee between RANZCOG and AGES. And I know, between AGL and ACOG, there's there's often difference of opinion. We're all about improving women's health. And I think we work really well together, which is really good. We have an amazing, very liberal college who support lots of different things. There's a lot of stuff in the media at the moment about the college supporting access to abortion care all around Australia and New Zealand, which there's been some issues with, but the college are very forward-thinking and very proactive on these sorts of issues.
It is my great pleasure to introduce Dr. Michael Wynn-Williams. He is a respected gynecologist and renowned endometriosis specialist, AGES RANZCOG Level 6. Michael holds a significant public role as the lead of Minimal Access Gynecology Service, or MIGS, at Auckland Hospital. Michael is the training director of the Australasian Gynecological Endoscopy and Surgery Advanced Training Program, or the AATP, which is widely considered the top training position in New Zealand. He is also an active Auckland Hospital Women's Health Pain Service member. Previously, Michael served as a senior lecturer with the University of Queensland and played a pivotal role in fertility treatments through Queensland Fertility Group. He's contributed significantly by establishing a fellowship program in collaboration with Eve Health and Mater Health, which aimed to train aspiring gynecologists in advanced laparoscopic surgery under the AGES AATP program. Michael is a dedicated educator, sharing his advanced laparoscopic gynecology surgery expertise with fellow doctors in Australia, the UK, Ireland, and Mongolia. He remains committed to mentoring and educating gynecologists across Australia and New Zealand. Since 2015, Michael has been the director of the AGES Laparoscopic Anatomy Pelvic Dissection Workshops, held 4 times a year at the Queensland University of Technology. In addition to his clinical practice, Michael holds local and international leadership roles in several organizations. He is the first New Zealander to hold the role of the president of the Australasian Gynecological Endoscopy and Surgery. He's an associate editor of the AEGL Medical Journal of Minimally Invasive Gynecology. Michael also sits on the Clinical Advisory Committee of Endometriosis Australia. In New Zealand, Michael is the Endometriosis New Zealand board member and chairs the Clinical Advisory Committee. So I want to welcome Michael, who I recently met when I attended the first AGES perioperative meeting, which was fantastic in Melbourne, Australia. I thought that was a very highly engaging, super interesting meeting because it was truly multidisciplinary. So I have to commend you on the meeting and also just the collaborative nature and highly engaged audience. So I hope you thought it was a success, because I sure did.
Kia ora, Amy, and ate marie, which is good morning in Māori. And thank you for your kind introduction. I'm speaking to you from Waiheke Island, about 30 minutes by ferry ride just north of Auckland, on Ngāti Whātu o Araki tribal lands. And yes, it was a great meeting in Melbourne, and that was our first perioperative surgical meeting. And the aim of that meeting was to break down barriers and silos. And we had surgeons and anaesthetists and theatre nurses and perioperative nurses and gynecologists. And we're really excited about that type of meeting where we all come together and talk about surgery and theatre and all the things that we're involved in. It was great to have you speak and share your experience, particularly on ergonomics. It was truly an amazing meeting, and thank you for coming. It was a pleasure to have you.
I know I just introduced you and we talked about a lot of your accomplishments, but I just wanted to get a little bit more of your backstory. I read about it on your website, but I think our listeners would be interested because you've actually trained in quite a number of places. Can you tell me a little bit more about it?
Yeah, I'm a bit of a nomad, and I used to turn up at AGES meetings. I've been in the UK, and they used to call me the nomad fellow. I'm originally from Christchurch. So Christchurch is the biggest town in the South Island of New Zealand. It's about 500,000 people. I grew up on a small farm out in the country. My mother's a midwife, and I had exposure to women's health from a young age, and it kind of drew me into doing obstetrics and gynecology. I did my medical training at Otago University, which is down south, is one of the closest universities to the Antarctic. Amazing medical school down there, and then did clinical years in Christchurch, and then did my O&G training. So we don't do OBGYN, we do O&G training in Christchurch. And I'll talk a bit more about how training works in New Zealand later on. And so I did that 6 years, and then I decided I was going to do fellowships, and I was really interested in endometriosis. So I ended up moving my wife and my 2 young children at the time, just at the turn of the century. So in 2000, we moved to Sydney, and I ended up working with Associate Professor Alan Lamb, who Alan is very well known to the AEGL community, an American community. He's been on the AEGL board, and I spent 2 years with Alan, and that was an amazing experience, learning excisional endometriosis surgery, complex advanced pelvic surgery. I did a lot of pelvic floor surgery at the time, and that was great, but I wasn't finished then. I actually decided I needed another fellowship, so I went to Glasgow in Scotland and worked with a team there, and that was amazing. And then I ended up doing another 2 years. I got a consultant job in Addenbrooke's in Cambridge, and I ended up sharing an office with Mark Slack. So Mark Slack's, again, well known to the American crowd. He ended up was part of inventing the new Versius Cambridge robotic system, which I think now is in the US. So he's a pelvic floor specialist. So he and I worked together for a long time.
You are a lifelong student. My goodness.
Lifelong student, and then moved to Brisbane, and I set up public practice and private practice for about 15 years. And that was amazing. And I worked with Anoush Yazdani. He's, again, well known to the AEGL community. He's been on the AEGL board. He and I set up a large private practice together. And then in 2000, I moved back to New Zealand and set up practice in Auckland. So that's where I am now.
What prompted you to do like 3 extra fellowships?
Because there's no rush. And I thought, I want to learn so much. And it's just a great way of practicing and getting paid for it. In Australia and New Zealand, we talk about practicing on the POMs. So, most people will at least spend some time in the UK and work in the NHS, because we have significant similarities between the Australian, New Zealand and the UK system. So going over and spending some time there, and all my senior consultants we call attendings, had done the same. So it was just a natural thing to do.
Oh, wow. Well, tell me a little bit more about your training in O&G, and then also kind of like the differences between all the places you trained in New Zealand and Australia. I think our listeners are going to be really curious about it.
Well, so training in Australia and New Zealand is run by an organisation that runs across both Australia and New Zealand. We have separate health systems, Australia and New Zealand, but we have a college called RANZCOG, so Royal Australian New Zealand College of O&G, and they set all the rules on how training works. They set out how long you're going to train for, and they run the exams, they run all the assessments. And training occurs usually after you've spent about 3 or 4 years after med school. So you'll finish med school, which is either between 4 and 6 years. So 4 years for postgrad programs or 6 years for direct entry programs. And then you'll graduate as a doctor, and you work as an intern for 1 year, and then you'll usually work as a house officer. So you're working on various teams. You're a junior as part of the team, and then you may progress to what we call senior house officer for a couple of years, and you may travel. You might go to the UK, or you might go and do locums. And I mean, I did locums all over Australia for a year. It was a great experience working in EDs and things. And then you might express an interest in a certain field because you've worked in lots of different things. You've worked in surgery and orthopedics, and you get and then you might do O&G, and you think, oh, I want to do this. And that's what happened to me. And in New Zealand, I did my diploma of obstetrics. I was thinking about doing general practice, so being a family doctor. And so you'll often do a diploma, and I did that, and I loved O&G. And so I just decided to do specialist training and applied in Christchurch at the time. And so nowadays training, there's about 2,000 specialists in Australia, and there's about 350 O&G specialists in New Zealand. And in each country, there would be maybe about 10% will be trainees. So there's probably about 200 trainees in Australia and about 100 in New Zealand. And they'll spend 6 years, so a 6-year training program. So it's a long training program. Once you're finished, you get your FRANZCOG, so you get your fellowship of the Royal College, and that's it. I know in the US, when you finish your training, you do some exams and bits and pieces a few years later. It's all done in Australia and New Zealand. You don't do any further. You're off. But you could also do subspecialty training after that as well. So you could do gynecology, or you could do ultrasound medicine, or you could do urogynecology. You can do fetal maternal medicine. I think those are the main ones. And that's another 3 years.
So that's 9 years total?
Yeah.
Oh, wow.
So we come out a lot older when we're finished.
Oh, wow. So then, but how about the MIGS route? That's not
so MIGS route's separate. It's not considered a subspecialty like the US. It's the same sort of thing. It's a 2-year program, and that's run by AGES. So AGES is the Australasian Gynecological Endoscopy Society. And so we run the AGES training program, or what's called the AATP, so AGES accredited training program. And I run one of those programs here in Auckland, and there's about 30 training centres around Australia and New Zealand. And it's a 2-year program. And again, it's kind of, it's run like RANZCOG training. There's various meetings you have to attend. You have to do, meet all these different criteria, do lots of surgery, regular assessments every 6 months. There's an exam. And that's been working really well. That was formalized in 2014. So we have a large number of people who have graduated through that program. And people who have graduated through that program then are considered levels. We have these various levels of surgery that through RANZCOG and AGES, and they're considered a level 6 surgeon. So they can do either complex pelvic surgery, including pelvic floor surgery. They can do advanced endometriosis, coordinate units, work with colorectal surgeons, urologists. They're all trained as excisional surgeons, so they're cutting out endometriosis. They may work in pain. They can have quite a wide practice profile.
That's super interesting about the different levels. Do you have to pass a skills test or a written test in order to determine that, or just by virtue of your training?
Yes, there's no test, but there is. So if you finish your RANZCOG, so that's your RANZCOG training, you're accredited up to level 3, potentially level 4. And so you just have to show evidence that you've done those procedures and you've signed off. And then if you've done AGES training or subspecialty training, so subspecialty training such as gynecology or urogynecology training, you would be at level 6 as well. And so those levels are used principally by hospitals that you'll go and work at to do your accreditation process. And then they can say you're allowed to do those procedures because you've been set at that level.
What do you think the likelihood is that MIGS will become an official recognized subspecialty in Australia and New Zealand?
Like America and Canada, it's a dicey issue. There's a lot of debate over it. I suspect eventually it will. Does it need to be? I don't know, but I think likely it will. And at the moment, when people finish their qualification, their AGES qualification, they don't even actually have any letters or anything after their name. But that's something we're kind of working on at the moment. And once that's done, then it may get some sort of formal subspecialty recognition.
Interesting. Well, tell me a little bit more about the interaction then between RANZCOG and AGES. Is that like a seamless partnership? Is that like something that you're nested underneath it, or it's separate? Like in the US, all these subspecialties are separate.
Yeah, so RANZCOG obviously is that we're all fellows of a college. So everybody who is O&G specialist, consultant, is a fellow of a college. And we all pay our dues. We pay regular fees to the college, and the college organise all sorts of things for us. They run annual meetings and smaller meetings. But the college is principally focused at O&G, and all the obstetrician and gynecologists. And obviously one of the big focuses is obstetrics. That's the big thing. We need lots and lots of obstetricians in Australia and New Zealand. We don't have enough. So there is always a big focus on obstetrics. I think at the moment, as president of AGES, I've really been trying to build the relationship with RANZCOG. It hasn't been great in the past, but I think we actually got a really good relationship with RANZCOG at the moment. We have regular meetings. We talk about things we want to achieve together. We actually have a combined committee between RANZCOG and AGES. And I know, between AGL and ACOG, there's often difference of opinion. We're all about improving women's health, and I think we work really well together, which is really good. We have an amazing, very liberal college who support lots of different things. There's a lot of stuff in the media at the moment about the college supporting access to abortion care all around Australia and New Zealand, which has been there's been some issues with it, nothing like the US, but the college are very forward thinking and very proactive on these sorts of issues. So we work really well together.
Yeah, that's pretty cool. I think that just the political environment is just completely different scenario, but for us it can vary, obviously, from administration to administration. Well, tell me a little bit more about working as a specialist in New Zealand and Australia. It was fascinating to me to hear that everyone kind of has a hybrid practice.
Yeah. So there's not everybody, but you can choose how you practice. And we have, so in Australia and New Zealand, there are, I mentioned before about kind of an NHS system. So it's a public healthcare. So public healthcare means that as a user of public healthcare, you pay no fees as a patient. You do not require insurance to see a doctor. So in New Zealand, we have Health New Zealand, which is the overriding body that runs public health in New Zealand. And in Australia, you have state-based systems. So in Australia, of course, we've got about 8 states. And so if we take New South Wales, you have New South Wales Health, with Sydney is the big centre for New South Wales Health. So those are all state-based and state-funded. And so patients will be referred, they'll see their general practitioner or the family medicine specialist who will do a referral to the public hospital. There'll be maybe a wait or a few weeks or a few months to see the specialist. And then you'll see a specialist, not necessarily of your choice, but a specialist. And then say if you need surgery or you need care, you'll be put on a waiting list. So you'll go on a waiting list for surgery, and those waiting lists vary depending on where you are. But you pay no fees. It's free. Okay. Your taxes pay for that service. For obstetrics, in New Zealand, we have a system that quite foreign probably to Americans. We have midwives as primary carers for our patients, and we have obstetricians who will help with that care as well. And that's been going for many years. In Australia, it's more of an obstetrician-based system, but they have midwives looking after everybody as well. So we have very strong midwife cohort in both countries. So that's the public system. Everyone has access to that, no question. And then you can also work in the private health system. So the private health system is where, as an individual practitioner or a group of practitioners, you get together and you set up a business. You set up what we call rooms, so a space where you see patients or examine patients. And that can be obstetrics or gynecology or both, or fertility, as I used to do. And you will see your patients, and they're your patients, and say they're going to have an operation. You will say, all right, I operate at this hospital, and we'll book you in for your surgery, and the patient will likely have insurance, so health insurance, and their health insurance will pay for their surgery or some of their surgery.
They have private insurance, like a supplemental private insurance?
Yeah, so it's they have a health insurance, they pay premiums, and it'll pay for the bits and pieces. So in New Zealand, Australia have different systems. So New Zealand has a health insurance system dominated by a company called Southern Cross, and they will pay for their consult fees, ultrasounds, investigations, MRIs, all of it. And then they'll have so the patient doesn't have any co-pays or anything, as you call them in the US. And then in Australia, they have a different system. They have Medicare, which is completely different to the American Medicare system. But they have Medicare, which is federally funded money, and then there's insurance as well. So it's a bit more complicated. And for anyone ever thinking about moving to Australia, one of the little traps that you can get in if you move to Australia from overseas is you need something called a provider number. You cannot work in private without a provider number. Without a provider number, you can't bill for Medicare. And if you can't bill for Medicare, patient can't claim for insurance. So that's a little trap. And we can talk about that later as to how to get a provider number. So essentially 2 systems. Sometimes they work together, bits and pieces, but it actually works really well. No system is perfect, though. And in Australia and New Zealand, there are big strains on the public health system. There are significant wait lists to get in to see doctors. There's wait lists to have surgery, and those get longer as health costs increase. And it's been, since COVID, things have been really quite difficult, particularly in the New Zealand health system. It's not perfect. We're only a small country. We don't have a lot of money. So that's caused some issues. But there are issues wherever you go in the world with health systems because they're like bottomless buckets. You just pour money in and it keeps absorbing it.
Yeah, it is true. It's not easy also to measure these outcomes. What are the wait lists like? Like 6 months to get surgery? 2 years?
So I left Brisbane just before COVID, and my wait list for surgery at that point for endometriosis surgery was about 18 months.
Oh, wow.
And I don't think things have got any better So in New Zealand, officially, you shouldn't have to wait more than 3 or 4 months for a surgery. At the moment, my wait list is about nearly 8-9 months. We're trying to get that down.
Wow. Yeah, it sounds like it. I mean, these are pretty big areas with a sort of a small population, but then relatively speaking, but then when you look at the population served and the number of physicians, you don't have enough, it sounds like.
Yeah, so there is a shortage, and we have the same problem that they're having in the US, that we've got a big retirement coming through. So we've got a lot of people retiring, and not necessarily, we're not bringing enough people through the bottom end. And so I think in Australia and New Zealand, we have one obstetrician and gynecologist per 100,000 people.
Oh, wow.
So both Australia and New Zealand are pretty similar. So New Zealand's population is 5 million. So we have about 300 specialists, I think. And Australia's population is 25 million. And the problem, so New Zealand's a small country, but we do have patients that are, we have quite a diverse population. We have a lot of people out in small rural and regional areas who do struggle accessing healthcare. We have a large Māori population, the Indigenous population of New Zealand, and we have a lot of equity issues of people, particularly Māori and Pacifica patients. So Auckland is the largest Pacific Island population city in the world. We have a lot of diversity here. So we do have equity and access issues. And Australia is very similar. So Australia obviously has its First Nations Indigenous population who've been in Australia for nearly 60,000 years. And they have, it's well documented, there's significant poor health outcomes in those populations, and often living in very remote rural areas around Australia. And I've just come back from Australia, and my wife and I drove from Darwin to Broome. So that's the top end, the very top of Australia, and very remote, driving through the Kimberley and things. And it was very evident the significant health inequities that were occurring on that trip that we saw. So there are significant issues because of geography in both Australia and New Zealand that need to be addressed. If you live in the city, in the big cities like Sydney, 5.5 million population, they've got amazing healthcare, big hospitals. Melbourne, similar. But if you live in smaller centres in Australia, smaller places, there are significant issues. And so you often have to travel long distances. And when I worked in Queensland, I would see patients. I remember a patient came to see me from Mount Isa. She'd spent 24 hours on a bus to come and see me.
What? Wow. That's crazy.
Yeah. And I serviced a population. When I was working in Brisbane, I was servicing a large population, so the Northern Territory as well. So that's up in Darwin. I used to have patients fly from Darwin. And that's a 4-hour flight from Darwin in a jet, come to see me.
Wow. That's pretty amazing. And then regarding the private practice and public practice, that's public. It sounds like the universities or the academics are all through the public university system. Is that right?
Well, yes and no. So so you can actually have private hospitals are affiliated with universities as well, and so you'll have medical students in the private hospitals in different places around the country in Australia and New Zealand. So we don't have separate academic hospitals that are separate to the public hospitals. They're integrated. So the medical schools will be integrated into all the public hospitals. So all the medical students will come through the public hospitals. You have a public position. You may have an honorary academic role. So I was always senior lecturer, but it's relatively easy to also become an associate professor and bits and pieces. And then you'll have people who work within the public system who have formal university roles who are, they might be part-time working for the university in an academic role or a research role. And, I worked in Brisbane. We had 3 medical schools within Brisbane. So there's the University of Queensland, Griffith and Bond, which was a private medical school. So a lot of integration with academia and the public roles. And so there's lots of different, you can do so many different things, which is great.
But it does sound like it's more the people that I met in Ages, it sounded like a lot of them have a private practice and then they go to the public hospital for like a day a week or a day every other week, and they work with the residents and teach the fellows, and it's just a different setup, it sounds like.
It's a very different setup to what you're used to. And I when I was in Brisbane, I used to work 50% in the public, and I would do my public operating in my public clinic, and that's where my fellow would do all their operating. And then 50% was in private, and my fellow would come with me and work with me in private and often assist me, and I'd let them do some surgery in private. And it was very busy because I had lots of hats on. I was also doing fertility practice. So I was often getting to work at 6 a.m, finishing at 6 or 7 at night, sometimes working Saturdays. So that was pretty full on, and that's not unusual. And then you'll have people doing their public work and their private obstetrics. And so private obstetrics, I've never done any obstetrics, but my colleagues will book themselves individually up to 30 to 40 patients per month in Australia. So they will be they'll have a large number of patients on their books in their private practices. So that's very, very busy.
How are they able to do all of that? Is that a solo practice or is that a group practice?
They can be sometimes solo practices, and they can sometimes be group practices. In the practice that Anusha Asdani and I set up, we set up Eve Health, we ended up building the largest group private practice in Australia at the time. We had 18 specialists in our group. Our group would share the weekend calls, so someone would be on call on the weekend, but during the week they would generally look after their own patients. It's just what you get used to, I think. And some of the older practitioners, I remember at the Mater, one of the biggest hospitals and maternity hospitals in Australia, they used to do 12,000 deliveries a year. And I don't know how that compares to the sort of US, but that's a lot. And some of the older practitioners near retirement, they were still doing 50 deliveries a month booking.
Oh, yes. Well, I trained in a hospital that was about 10 to 11,000 deliveries a year. And then my mom was also a private practice OBGYN, and she would deliver between 30 and 40 babies a month by herself, solo practice. So I have a window into
you got an idea.
The volume, and that is very, very busy on top of trying to do all the other things like operating and seeing patients in the office, and you have to drop everything. And so I have a lot of respect for that grind because it's not easy. And then the other thing that I found very interesting is also the fact that so many people do fertility there, because it's like you contract with a lab. Like here, fertility treatments are definitely beyond doing a little bit of Clomid. I would say most people just get referred to REI.
And so in Queensland, 80% of practitioners did some form of fertility. I did fertility for 14 years and I enjoyed it. It was particularly because my practice was, endometriosis and pelvic pain. You have a lot of patients you can really provide a holistic care. Although I didn't do their deliveries, but I could help them get pregnant. And I was affiliated with a fertility group. And so often in the morning, I would go and do a ward round and then go and do egg pickups and then go to theatre and do my operating all day and then catch up on admin. It was really long days. But I really enjoyed it. But I've given up that fertility practice since I've moved back to New Zealand. I've really calmed down the amount of work I do now. And I only work 4 days a week, so...
That's great. Well, that's another thing that I thought was interesting because it sounds like the insurance pays for the hospital stays, so there's incentive there, whereas we've moved all towards same-day surgery, and then everybody is rounding at 1, 2, 3 hospitals, and they have a couple people here and there. And for benign, at least, most of our practices have converted to outpatient, and that has happened for us over the last 10 years, but I would say it's pretty rare now for Urogyn or MIGs to have a big inpatient service. So how long do you think the stays are on average?
Depends on whether you're in public and private, but, typical TLH in public, so total laparoscopic hysterectomy will stay overnight. We've actually just started up a day case hysterectomy program just because of all the pressures on the system. And was one of the workshops we ran at the perioperative meeting in Melbourne was day case hysterectomy. So we're really trying to encourage it. But, because the insurance companies, they're so used to paying for overnight stays, it's just become normal practice that people will stay 1 or 2 nights in hospital and they like it. They pay their insurance. Why can't I stay in hospital? So we're trying to gradually change that, but it is a nice system. And I, in my private practice here in New Zealand, patients will typically stay a couple of nights and I'll go and do a nice little ward round in the morning, and I don't mind that.
Yeah, that is interesting. Well, let me circle back to, you alluded to this before, but the city practice versus the rural and regional practices, how is it structured and how are people addressing the equity issues? And, you have a New Zealand perspective as well as Australian perspective. I am curious because I just read something in JAMA Surgery, I think, about how they had minimum case volume or minimum case volume numbers, and actually with time, with better adoption of like ERAS and techniques and best practices, those numbers have gone down. And so is arguing against regionalization of care, because that's a big theme across any country I think you're going to find.
Yeah, and it's a big issue for training. So I'm sure in the US, there's always the conversation about, should we be splitting O&G training? Do we need generalists? Because there's the pressure on getting surgery numbers during your training, and a lot of trainees in Australia and New Zealand struggle to get the numbers, and I'm sure it's the same in the US. So they come out not necessarily fully trained. But one of the problems in Australia and New Zealand is we have such a tyranny of distance, and we need our rural areas. They are the lifeblood of our countries, farming areas. We need healthy rural areas. And one of the things that keeps a rural area healthy is having an obstetric service. If you have people who move to an area, a small area, and there is no obstetrician and you can't have a baby locally and you have to travel 1,000 kilometers to a city to have a baby, then it's going to be a disincentive to move somewhere like that. So it is really important that these areas have healthy obstetric services and have access to good women's health care. And, as I mentioned before about rural areas and indigenous populations living, so if I think about Gisborne, so Gisborne is a regional town on the east coast of New Zealand with a large Māori population, and they have every right to have good women's healthcare. So we need to provide them with the services, and we need to provide them with the specialists. Now, interestingly enough, we can't get many O&Gs to go to Gisborne, but at the moment, that department is actually mainly staffed by American obstetrician gynecologists. One of the problems we have in New Zealand is New Zealanders love to travel and work overseas. It's a thing we've always done. So I think nearly a third of New Zealand's population, so our population is 5.5 million, but we have 1.5 million people living overseas and working overseas.
Wow. It must
be
the adventure.
We're adventurers. We're diplomats. We do all sorts of things. We travel, we work overseas. And that's why, I went overseas for 20 years. And we often come back. But we often struggle staffing smaller, particularly in women's health, smaller centres. Now, Invercargill Hospital, which is down the very bottom of New Zealand, and again, it's probably the hospital closest to the Antarctica, great place, but it's actually mainly staffed by Americans and Dr. Mama Jones. So Daniela Jones actually works there. She's been there for the last 5 years. And she's very famous in America, around the world. She has, I think, 4.5 million YouTube fans.
Yeah.
Always amazing educator in women's health issues. And she's based in Invercargill.
Yeah, another friend of mine, or acquaintance, she moved from DC, is an OBGYN in New Zealand, and she just posted about, traveling to Bali. It's not so far for you all to go to Indonesia. So you said to me that a lot of people are reaching out to you for jobs. Tell me a little bit more about when that started and what that process is. How many requests are you getting a week?
Beginning of the year, I'm not sure what happened in the US, but there were I was getting an email every week of people saying, are there any jobs? I want to move to New Zealand.
Yeah, I believe it. Yeah, there's been a lot of news lately, so.
Yeah, I don't know what that's about.
Right.
But there is similar expressions of interest in Australia. And look, it's natural that Australia and New Zealand are amazing countries. We have really good health systems. There are problems, but every health system has problems. We have public system, it's a private system. There's a lot of clarity around that. You can do so many different things. And we also have amazing countries. We have, New Zealand. I think about the things I do here. I mean, I look at my view out here. I'm looking at the Hauraki Gulf, where we have whales, dolphins, and I'm half an hour north on a ferry from Auckland. And I can go mountain biking today. I could go bush running, bushwalking, tramping, as we call it. So you guys go hiking, we go tramping. So that's when we go bushwalking, and we have amazing huts around New Zealand. So you've heard of people doing the Milford Track and the Rootburn Track. We have all sorts of incredible things, mountains, skiing. I mean, I grew up in Christchurch, where we could drive for an hour in the morning and end up on the ski field and ski all day. Just fantastic country. And then Australia, there's so many different things you can do in Australia. You've got the ocean, you've got the deserts, you've got the bush, you can go skiing. So incredible countries with great democracies, stable government, really interesting places to live and work. So why wouldn't you want to come and work in Australia?
I know. I was going to say, you're selling me now. I mean, I when I went there, I was like, oh, I'm ready to move here. My husband was not as ready to move, that I asked him about it because I think it's fantastic. If somebody were to try and move, like how easy is it to transfer? Because I know for foreign trained, international graduate, it's very difficult to come to the U.S. and practice.
It is, and we have people from here that go to the US and they have to sit all their exams, the UCMLE and things like that. It is tricky, and then there's all your green card issues and bits and pieces as well. And obviously that's got a bit more difficult. You need to do your research. That's the key thing. You can come as a trainee. So some people come as trainees, and so you may have been a resident in the US, and then you will apply to RANZCOG for accreditation of the training you've done, and they'll assess you and say, right, you've done this much, you need to do this much more, and you'll get on a training program, get a job and get on a training program. So that's one way of doing it, and some people do it that way. We've seen a few Americans do that. Or you come as a specialist. And I guess Australia and New Zealand have different processes. So you've really got to do your research. And the first place you would go to is RANZCOG, so our college, to ask the questions as to the process. But specifically for New Zealand, you would be approaching the Medical Council of New Zealand and talking to them. And there are different ways of doing it. And an American friend of mine told me one of the secrets to getting, if you want to get a job quickly in New Zealand, is you apply as a locum tenens. And so it actually can give you up to a year's registration as a specialist. So that's an easy way of doing it. But at the same time, you apply for your specialist recognition through the Medical Council and then through RANZCOG. And that can take a few months. And then our college, so RANZCOG will assess you and say, all right, you're a specialist, this is where you went to med school, this is where you've done your training, we think you're equivalent, but you need some supervision. And they'll say you need either 12 to 24 months of supervision. And that is really, you've got a job, working in a hospital, you have a supervisor, and you're going to meet with them regularly and say, things great. Or they might say, there's a problem here, we need to sort that out. So that's actually pretty straightforward. You just need a supervisor. You need a job first, though, as well. And you might go, there's a website in New Zealand, kiwijobs.co.nz, and you'll see all the jobs there. And there's various there's a number of ONG jobs in New Zealand up at the moment. There's actually an associate professor job at the Auckland University, where I work, up for grabs at the moment as well. With Australia, it's a different system. It's a bit more complicated. And again, you go not through the Medical Council, but through RANZCOG. So you need to talk to them, get a job again, and then there'll be some supervision stuff. If you want to work in private, I mentioned the thing about the provider number. So the provider number is a special number that the government give you that will allow you to bill for Medicare, which is government funded. And then if you can bill Medicare, then the insurance companies will allow you to bill as well. Now, they've really restricted provider numbers to overseas doctors, and you have to work in an area of need to get a provider number. So you might have to work in a rural and regional area. These are still great hospitals. They're great lifestyles. You can do your sea change or your tree change. Do you know what I mean by that?
Mm-mm.
So in Australia and New Zealand, they talk about, so if you're living in the city and you want to go work by the sea, you do a sea change. Or you want to go work in the bush, you go do a tree change.
Oh, I love it.
So you work in these small centres, and they're still amazing, and they'll have private hospitals, and you can have a great lifestyle and work 9 to 5 and not have too much stress. You might be on call once a week or something like that, but you can go and work in some amazing places. And there are lots of jobs up for grabs in Australia at the moment in some very nice places. You can live in a house by the sea with not too much difficulty.
Oh, that's pretty amazing. That's interesting.
The key thing is to do the research.
Yeah.
And RANZCOG is your place to do that. Don't just turn up from America and say, here I am, give me a job.
Oh, has that happened before?
Well, there are people who are driving taxis around Australia because they just sort of turned up expecting to get a job.
Oh, okay. I would not do that, but I'm also, like I'm more of a planner than that.
Yeah, you have to plan ahead, do your research. A lot of that stuff can be done while you're at home in the US because they want a lot of paperwork as well. They want every certificate you've ever received, and usually the paper copy.
Oh, interesting. And then tell me, like, what is it like for the medical legal environment? Are people as fearful about lawsuits like on the obstetric side as the US, or do you think it's less so there, or how is it for gynecology?
So it's very different in Australia and New Zealand. So I'll talk about Australia first. So patients have lots of patient right charters in Australia and New Zealand, and patients can complain if something goes wrong or they're not happy with you, and there's various state bodies and government bodies that they can complain to. In Australia, if you're really unhappy, you've had a bad outcome, you've got unexpected costs, you're not happy, you can sue. So, of course, one of the big things that people sue for is poor obstetric outcomes and babies born with cerebral palsy. So quite a few years ago, there was some really big lawsuits with large payouts, sort of $12 million, $20 million. And as a result of that, there was a medical legal crisis, and the insurance companies insure the doctors sort of nearly went under. And so as a result of that, the state governments had to impose limits on how much you can sue for. So there are sort of kind of limits in Australia as to how much you can sue for. So as an obstetrician, say a busy obstetrician, from what I understand, so if you're a busy private obstetrician, you'd be paying about $130,000, maybe $140,000 in insurance premiums every year.
Wow.
But you're making, you're making a good income. That's for an obstetrician. As a gynecologist, a private gynecologist, I used to pay about $30,000 a year in Australian dollars in insurance premiums. I do sort of a lot of medico legal work and sort of defending particularly MIG surgeons against outcomes. And it's often things don't go to court. There's often sort of out of court settlements and things like that. So it's not too bad. So that's Australia. In New Zealand, we have a very unique no-faults compensation system called accident compensation. So you cannot sue for medical misadventure. You cannot sue. So if I have an injury, I fall off a ladder because my employer told me to go up a tree, I cannot sue the employer because ACC will look after me. So ACC will look after sports injuries, motor vehicle accidents, work injuries, and health-related poor outcomes. And so there's no medical legal fees from that. And so I pay $150 a year in insurance premiums to my insurance provider.
ACC is the national...
ACC, Accident Compensation System.
Oh, okay. A national, like a federal kind of insurance?
It's a state system paid for by, it's a levy on some taxes and bits and pieces. So that works really well. You can still, people still have, there's health charters and bits and pieces, so people can still complain. And then we have the Health and Disability Commissioner who will accept complaints and then make reports on those, but you cannot be sued. If you do something really bad, you'll go to the medical council and you could be struck off, and same in Australia and New Zealand. Like
a medical license or medical board kind of investigation or something. Okay.
Yeah.
Tell me about the reimbursement. I mean, we've had a lot of talk in the US about gender-based reimbursement, and it's higher for the male-based ones, possibly, compared to the female ones. And it sounded like maybe it's similar over there, number one. And number two is, I was kind of surprised to hear that comparatively, Urogyn was like maybe less remunerative. But I'm curious about like obstetrics versus gynecology, the different subspecialties, male versus female. What is your impression?
So the big issue is in Australia the Medicare. We talked about Medicare, so the state-funded system that funds a lot of or funds everything in health, but there are significant gender inequities within Medicare. And there's actually a review of this at the moment. And one of the examples that is frequently cited is the fact that if you have a pelvic ultrasound, a female has a pelvic ultrasound, I think Medicare will pay $150 for that ultrasound. But if you have a testicular ultrasound, which takes about 5 minutes, you'll get about $450. So it's like, well, that doesn't make sense. And so there's a lot of that within the Medicare system. The Medicare system was developed 30, 40 years ago, and it's very hard to change because it's a federal system. And so, yeah, there are very significant inequities within that system. With regard to surgery and things, it's not too bad. It's more the ultrasounds and things. But there is a government inquiry into it at the moment, and it'll be interesting to see what happens from a change point of view.
I know in Canada, a lot of people just keep on practicing obstetrics because it's more lucrative. Is it the same thing?
You'd probably, if you did a gynae practice versus a obstetric practice, you're probably earning more in obstetrics if you're just doing private. So gynae is the sort of poorer cousin, but I'm not complaining. I have a nice lifestyle. I'm able to pay my mortgage.
Yeah. Well, it also sounds like the malpractice insurance is way more expensive, but it does pay for itself.
It does pay for itself. I think and they have a step system. So when you're starting out, when you're beginning, say, an obstetric practice, they will step the insurance depending on how much work you're doing. It's usually based on your income. So it's not like you go out and you haven't earned, you haven't even seen a patient and they're suddenly charging $130,000 a year. So they've got, I think they're really sensible in helping people develop their practices, because that takes time. But it's interesting that the new generation coming through, and you're probably noticing this, are more about lifestyle. They don't want to work the long hours. They're certainly not booking the huge numbers of, say, if you're doing obstetrics, they're not booking the large number of cases. They're more likely to work in a group practice. So things are changing. So we're actually going to need more obstetricians and gynecologists. So currently, from a gender point of view, I think 70%, nearly 78% of our practitioners are female, and people are wanting to work less hours. So we need more boots on the ground.
Yeah, it's hard to increase the number of spots here because our GME spots are funded by Medicare. And I know at the Cleveland Clinic, we have an excess of what our funded spots are. So it can be quite difficult. And, those numbers are always a problem in terms of training numbers. Is that also a state or federally controlled situation?
It is, and to try and increase the numbers is really hard. But it's if you increase the numbers, then you potentially dilute the experience as well. So it's finding that balance. And in Australia and New Zealand, everyone's focused on getting their gynae surgery numbers. They do so much obstetrics and Caesars, cesarean sections and things that's not a problem. It's getting the gynae numbers. Now, one thing I need to mention, those who do obstetrics who are thinking about moving to New Zealand, the big issue that is frequently highlighted is the use of obstetric forceps. So we frequently use forceps. So a lot of obstetricians who move to New Zealand haven't done forceps and they've just done ventouse deliveries and things. So it's important to be able to do that as well. The other thing that really is important to be aware of is, obviously, a lot of generalist OBGYNs in the US often do a lot of primary care. We don't do that in Australia and New Zealand. We are all specialists. So everyone you see has either significant obstetric problems or significant gynae problems. We don't see people for their annual pap smears or their breast examinations. It's all problem-based stuff, not primary care.
Oh, interesting. Well, that's better because that's more top of license stuff. It's interesting because I think that the volume for gynecology is totally regional here. I mean, in the Midwest and the South, we have much higher hysterectomy numbers. It's just a more of a cultural thing. And I was just talking to somebody in education today. We have so many cases that are uncovered, like great cases, like robotic hysts, endometrial cancer, vaginal hysterectomies. It's crazy. Like our program, we have a tracking program but we have so much volume. It's very interesting. Whereas every other program I'd been to, the majors all were covered by residents, but it's just a totally different setup. I don't know what the right answer is.
It's finding that balance. And that's why AGES and RANZCOG we have regular meetings. It's really hard. And there are a lot of people, are advocating for splitting specialties. But I don't think that's the solution. I think it's about picking people early to either do obstetrics, people to do, minimally invasive surgery, gynae-onc, pick them early, and then pick our generalists who want to go and work in the rural and regional areas and support them well. I think that's pretty important. And that's one of the roles of AGES, is to run meetings and education. And we run 3 big meetings a year. So we run our ASM and then 2 other meetings. And so our next ASM, for anyone who's interested in working in Australia and New Zealand, come to our ASM in Auckland next year, March 12th to 14th. Great opportunity to meet lots of ONG specialists from Australia and New Zealand and to have a look around and see what you think.
I have heard only great things about New Zealand, number 1. And number 2 is I have been so impressed with just it's very collegial. I think because it's a very small community. I mean, like you said, it's only a couple hundred people. It's very friendly. It's very collaborative. And then the perioperative meeting, I know I was meeting the creme de la creme, the believers, but I was kind of surprised to see so many colorectal surgeons who people collaborated with. I don't think here, the colorectal surgeons, I don't think they're as enamored of the endometriosis cases, let's just say. But it sounded like they enjoy it.
Well, it is very variable. And I mean, I've always very lucky. I've always developed good relationships with colorectal surgeons. And so tomorrow afternoon, I've got a case that we'll be doing an anterior resection on. I'll be doing hysterectomy. This colorectal surgeon will come along and I do a regular list with him. And usually these cases need an anterior resection. I'm a surgeon sonologist, so I do my own ultrasound scanning. So I'll assess these patients. So I'll scan them, assess their rectal disease, and I'll decide whether I can do a rectal discoid resection myself. So I'll cut the endometriosis out of the rectum and repair that, or whether they need an anterior resection. And it's interesting about endometriosis ultrasound scan. So we've been, Australia and New Zealand, well, particularly Australia, has been doing endometriosis ultrasound scanning for the last 20 years. I know there's a big excitement in the US at the moment about endometriosis ultrasound scanning. It's as if you guys invented it.
Yeah.
But actually, we've been doing it here for a long time. And Matthew Leonardi, who's, he's amazing. Matthew did his training with George Kondos in Sydney. Learned how to do endometriosis ultrasound. So it's quite funny. So it's well integrated into practice here. A lot of surgeon sonologists, a lot of really good ultrasound women's health practices who will do full endometriosis scanning. So that allows you to work very closely with colorectal surgeons because you know exactly what's going on, which is really good.
That is just fascinating. Well, I do appreciate you taking the time with all the time differences between New Zealand and the US. And I know many, many listeners are going to be very interested in this. I know because when I'm on these social media groups, people are always asking about it. So
well, I'll be, I'm on the JMIG board, so I'll be at AGL in Vancouver. So if anyone wants to talk about moving to Australia and New Zealand, I'm always keen for a beer.
Absolutely. I love it. No, you guys know how to have fun. I can attest to that.
Excellent. Yeah.
Well, thanks so much for coming on the show, Michael, and have fun in Vancouver. Unfortunately, I'm not going to be there because I went to another meeting this year, but I'm going next week to AUG, so I'll be able to at least have fun in Vancouver. I'll have some pre-fun for you.
Hey, before I go, one thing I do need to point out, one of my American colleagues said, so you need to know in Australia and New Zealand, you get 6 weeks annual leave paid. You get 2 weeks of CPD leave paid. And then you'll get money for your CPD, continuing professional development, or CME.
Oh, wow.
And then so in New Zealand, if you're full-time public, you'll get $16,000 to spend a year on conferences and flights and things like that.
That's crazy. What am I doing here? You're selling it, Michael. But anyway, I'm sure after this episode goes live, you'll get a lot more requests. Reach out to him. He's on social media, Instagram, Twitter. He has a website, LinkedIn. And thank you so much for coming. Good luck with the rest of your presidency of AGES. And good luck with the meeting next year.
Thank you, Amy. It's been a pleasure. Kia ora. And I look forward to entertaining you in New Zealand one day.
Thank you so much for listening. If you haven't already, make sure to follow the podcast, rate it 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable OBGYN on Instagram, Twitter, or LinkedIn. BackTable OBGYN is hosted by myself, Mark Hoffman,
and Amy Park.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz, with support from
Taylor Spurgeon-Hess and Yvonne Orgodzinsky.
Show notes and social media by Emma Landenwich and Lindsay Beecham. Administrative support provided by Judy Dela Cruz.
Music written and performed by Scott Baby Daddy Hoffman.
Thanks for listening, and we'll see you again next time. The views and opinions expressed by the hosts and guests on BackTable OBGYN are their own, and do not reflect the views or positions of their employers or any